So since about January 2014, I've been working with medical students to facilitate patient shadowing experiences as a way of gathering information and quality improvement data. We had an update day that spoke about patient family-centred care, which is a model of healthcare that we believe at in Alder Children's Hospital. And the feedback or coming out of that was this idea that we could do more, we could achieve more, and how was it possible to do that? And then I came up with the idea of using a shadowing experience by medical students as a formal method of collecting data on the quality we provide through our services. I came up with the idea initially in October 2013. I had my light bulb moment, was given 2 weeks to put together a presentation for the exec board on what my vision of how we could use patient shadowing by medical students was. I started with a proper kind of background research into what was patient family-centred care, so Anthony de Goya's work from UPMC, taking it back to grassroots level, what was the methodology of collecting data, why should you do it, and applicably in PEDS, why should we try and make a interaction with the health service as beneficial to the child as possible. So knowing that adverse interactions can affect your long-term psychology, your long-term mental, physical health, it seemed important to try and reduce those adverse interactions, and making that argument to the exec board, showing how we could address that through patient shadowing, through quality improvement feedback, and then change our services was my successful approach. I gave that presentation, received their support, and was told to kind of go out and make it a practicality with the ongoing support of the COO and one of the A&E consultants and one of the paediatric surgery consultants. So we had a kind of busy winter, and then in January 2014 started with our first group of medical students shadowing patients through their day case surgical procedures. Anthony de Goya's work from UPMC have a well-established toolkit for shadowing, how to design a shadowing experience, how to run it, how to collect data. So we took that, we looked if it was applicable to the NHS, to medical students, and then feeling that it was, we gave an introductory lecture to the students where we said, this is patient shadowing, this is how you go about doing it. These are the patient shadowing advocates we've set up on the day case unit to facilitate your progress. At that point, we didn't know whether they were going to get any meaningful data or not, so we just kind of turned that first lot loose, 35 of them in pairs or threes onto the ward. They were given a family and a patient to shadow, and they just collected data for us. Observational data, which we then analysed to look if we could find any meaningful quality improvement outcomes from. The patients and their families were introduced on their admission to the ward to the idea they might have a student join them to shadow them. We produced a frequently asked question guide for the patients and the families that basically said what student shadowing was, what we aimed to do with the information, and that they could say no to it if they wanted to. And the idea being that the student would then establish a rapport and a relationship with the patient and the family over the course of their admission, and not only record what they felt about interactions, but also direct feedback that the patient and family were giving them. So proper, quotable data. That first lot observed a lot of good things that we knew we were doing right. So they observed a lot of good communication, a lot of good examples of consent taking. They also observed some negatives. So that first lot noted there was poor communication around the prescribing of a pre-medication, and patients and families didn't know what medicines they were taking or why. So right from those first 35 students, we were able to say, hang on a minute, I think we've got a meaningful quality improvement tool here that is actually quite sensitive. Initially, if I'm honest, we build this mainly as quality improvement. We didn't think as much about the medical students as we should have done in the first instance as to the learning outcomes from them. But the feedback we got was that they were enjoying it. And actually, as we progressed it, cohort of student after cohort after cohort, up to probably the fourth or fifth, they began to tell us they were learning things that we hadn't anticipated, benefiting their education around what's called the hidden curriculum, so ideas of formal things we can't teach them, but they can learn through observation, through interactions. This actually led us over the summer, so August, September 2014, to write an educational proposal for the University of Liverpool School of Medicine on a kind of vertical curriculum strand to say this is what we can teach them in the third year based on their feedback. This is how we can then feed it back into the fourth year students that come back, and just keep building on the ideas of patient family centred care, quality improvement, empathy, compassion development during studies. So we've shown that we've improved facilities within the waiting areas for the parents and for the children. We've also got quantifiable evidence about improving the communication around pre-medications. So patients are now clearer, it's clearer what they're receiving, why they're receiving it. We can also show some evidence of this supporting other near-miss events as quite a sensitive tool as well for quality improvement.